All right, well, we're going to go ahead and begin. And thank you for coming to our slightly delayed March. Well, hopefully everybody enjoyed spring break version of Global Public Health Grand Rounds. First, I want to thank our presenters, Dr. Akiko Kamimura and Kyle Myers, for coming today. And for taking some time out of their schedule. We've had Dr. Kamimura here before, and it's been a pleasure. And so we've been looking forward to her bringing back some additional information that she's found over the past number of months with her collaborators. So by way of introduction, Dr. Akiko Kamimura received her PhD at the University of Michigan and is currently an assistant professor here at the University of Utah in the Sociology Department, and specializes in research into healthcare, systems, disparities, policies, and social determinants of health. Working with her as her research assistant is Kyle Myers, who is a PhD candidate who is very interested in the areas of reproductive health and underserved populations. So with their expertise and background today, they're going to give us a presentation on the title that you can see in front of you. I will not belabor the point, and please help me welcome Dr. Kamimura and Kyle Myers.
Something is coming. Oh. Thank you for coming. I'm very excited about presenting this study because I have done some global health research projects with Asian countries like Japan, China, Vietnam, and India. But all of the past projects are with academic institutions. So this is the first project with the community organization. So I really enjoyed working with the people and the community organizations in India, and I found that the things are very, very different from the working with people in academic institutions. So there are the collaborators in India, Vikas and Tommy. Both of them are at the Catholic Health Association of India. The association is called CHAI. Sounds really nice. And they cannot be on a webinar today because he's getting married this week, so he's too busy. But their colleague, Krithika, is on a webinar right now. So hopefully she can jump in some discussion. And I want to acknowledge these people. Actually, this particular project was done with the Navjeevan Trust. This is a community organization in Gujarat, India. And also this collaboration happened because of the Dr. Steve Ott and the political science department here. Something came up again. And Dr. George Parkinson at the Duke University helped the translation quite a bit because we translated the survey materials from English to Gujarati. It's the most common language in Gujarat. And I will explain about these things more details later. And I want to acknowledge Dr. Mieko Yoshihama at the University of Michigan, because we used the measures of abuse experience from her study. So I got the permission from her that she was actually on my dissertation committee co-chair when I was at the University of Michigan. So at first I want to explain about the CHAI a little bit. So CHAI was founded in 1943, so that's 70 years ago. So it's a very old organization. Then the CHAI has a national and international network. and has 11 regional units and has more than 3,000 member institutions in India. So the CHAI itself is really huge. And what CHAI is doing is, CHAI is basically the, want to promote community health. Oh, this one, that's why. So the CHAI has been working in both the communicable and the non-communicable diseases, and also they provide some relief to disaster victims, and they're working on advocacy also. Fine. So this particular project was done in Gujarat and India. So the red part is Gujarat. So population of the state of Gujarat is about 20 times more than the Utah population. 89% Hindu, 9% Muslims. So it's a little bit more Hindu people than the average in India, because about 80% of people in India are Hindu, so they are a little bit more. The Gujarat is pretty much doing well in terms of industries. The agriculture, tourism, electrical engineering, textiles, chemicals, and cement, kind of like a growing economy. So this particular study was done in Rajkot. How to use this?
Here is the laser.
Oh, this one.
Yeah.
Oh. Oh. So Rajkot here, the city of Rajkot. So Rajkot city is the fourth largest city in Gujarat. So the population is 1.28 million. So it's city, but it's huge. And actually almost 100% of people in Rajkot city are this Hindu. And Rajkot city is actually famous of the jewelry market and the silk industry. It's pretty much really the urban area. So why the collaboration happened? So the Steve Ott in political science department here mentioned about Tommy, the director of the CHAI, when I was chatting with Steve. And the thing, so the Tommy, they got the PhD in social work from the University of Utah. So the Steve was on his dissertation committee. I don't know when it was, but it was before I came here. I came here 3 years ago. Then told me they wanted to have a collaboration with someone in the global health here before I came here. Then the person who was asked by Tommy said no, actually. So it happened before I came here. Then when I was chatting with Steve, Steve mentioned about it. Then I said, I'm interested in it. Then Steve introduced the Tommy to me by email. Then I sent the email to the Tommy. Then that's how we started. So at that time, the Vikas, another collaborator in India who is working with Tommy, was not at the CHAI yet. So I started communicating with another person. Then the things that what they wanted to do is actually research. They are very interested in the developing collaborative research projects. But they didn't have particular topic. So they have a broad interest. Then they wanted to do the research and they wanted to apply for the grant. So I thought that it's important to focus on something at the beginning, and need to think about what we can do at the beginning. Then actually, around winter break, the person who originally communicated with me, they left Chai. Then Vikas started working for Chai. Then Vikas was very, very excited about this collaboration. So then the things started moving faster. Then we actually started the preparation of the first project in the spring. Then what to do first was really difficult because at the beginning we didn't have any funding. And also their interest was really broad. So what I did was I sent my articles, which I have done with the community organizations here. Then I asked them if there's something is interesting for them. Then we narrowed down the topic for the first project. Then we decided to do the some research on women on the abuse experience on the health issues. That actually I have done here and in Japan also. And I have some projects related to the violence against women, the health in China, Vietnam, and India with different academic institutions. So then we decided to do it for the first project. Then I started preparing for the IRB and also the translation. Translation was really difficult to translate from English to Gujarati. I don't know anything about the Gujarati, but it looks really very different language. So I asked them to translate from English to Gujarati. Then another person did back translation from Gujarati to English. Then the meanings became very different for some of the questions. So Dr. Parkinson at the Duke University, who created one of the measures which we used, actually found someone who is fluent in Gujarati in North Carolina. Then we communicated quite a bit. Then we finally made a final version. The complicated part is I don't know anything about Gujarati, but I have experience in translation of the Japanese materials. So the thing is that even if the forward translation is correct, sometimes the back translation becomes wrong because the range, each language has different range to cover the meanings. So that's why it took so much time. And also, I don't think Vikas and Tommy, they actually speak the Gujarati. They are not in Gujarat, actually. They are in Hyderabad. So, so they had to communicate with the people in Gujarat, actually. So I communicated with the Vikas and Tommy. Then they communicated with the people in Gujarat. So it was really complicated. So it took time to prepare for the IB, but then we actually collect data in the fall. But first of all, here is the purpose. So we decided to describe the lifetime prevalence of intimate partner violence. We focused on spousal violence only because in India, especially among the lower the social class people, it's not still common to date before the marriage. So we focus on spousal violence as intimate partner violence, and the childhood abuse and the abuse from in-laws, mostly their parents, their husband's parents. Then we examine the association between the intimate partner violence and the health and well-being. So among the women utilizing community health services, therefore the economically disadvantaged people. So the community health services, particularly for the economically disadvantaged people. So those are the results from the previous studies in India. Lifetime prevalence of intimate partner violence is almost 40%. This is much higher than the US average. In the United States, it's about 20 to 25%. And in-law abuse in India, 26.3%. I don't think this is common in this country. I don't think there is data. And the physical or the psychological childhood abuse among girls, 20%. And the sexual abuse, the prevalence among girls, 25%. So 1/4 of girls have been sexually abused in their childhood. And the combined boys and girls, 30% of the kids have witnessed father beating mother. So those are the results from the previous studies. And why it's important to focus on the community health service organizations. So we focused on the women using the community health services, which particularly for the economically disadvantaged. So it meant that they don't have access to the regular health care. And possibly they have a poor health, and also they may have the higher risk of intimate partner violence. But we don't know much about it. We just have more national statistics. And also there is no knowledge about what community health organization can do to prevent or intervene the intimate partner violence in India. So hopefully the information we got from this project will help to develop some prevention, the intervention, the programs there. So without funding, we had a lot of limitations, so that we decided to do self-administrated survey, which cost not a lot. It didn't cost a lot. And we surveyed the women 18 years old or older, and they utilizing community health services specifically for the seasonal illness. So nothing related to intimate partner violence. They just came there because they had the flu, something like that. Then because it's a self-administrated survey, we had to exclude the women who can't read. So actually we prepared both English version and the Gujarati version, but nobody took it in English. So it became the women who can read Gujarati. And the 11 staff members of the community health centers actually they did data collection as volunteers. So it was about 3 hours per day, 47 days in total, the last fall. Do you have any questions? I just keep talking.
So
yeah.
These women, they came in by themselves. Was it sort of voluntary that you guys think build their households?
Right. So those are the people who came to the clinic. So the interesting thing is the most people who go to the community health services are women. So this is perfect for our study because we are serving only women. But actually what they said is most of the people who go to the community health services are women. Any other questions? So the survey instrument, I have only the English version with me, but it consists of the demographic questions and Duke health profile. It's about the health and dysfunction. PHQ 9, about depression. PHQ 15, about somatic symptoms and abuse experience, spouse, in-laws, and childhood. We try to pick the standardized questionnaires which have been used in many other countries, hopefully in India, not necessarily in the Gujarati, but at least in a Hindu. So those are the demographic questions. Actually, the demographic questions are basically developed by the Vikas and Tommy. So I sent them the we may want to ask, like the age, education, employment, that kind of the information, overall information. But I don't know, about like how to ask education level there, because here it's different, right? It's probably like a high school diploma or less or something like that. But I didn't know where we should start. Oops. Like the employment, how to ask employment to the people, the women, in the Gujarati. So basically they made the demographic questions. Age, it didn't matter, but the education, they started from less than primary, so less than 4th grade, to the bachelor's degree, so categorically. And the employment, actually they put working full-time, working part-time, unemployed, but I asked them what did the working full-time mean for the women in the Gujarat. Do they kind of like think about the same thing about the full-time job? So that kind of like thing that we had to check each of the demographic questions. Yeah. Yeah. We used the consent cover letter. So one-page consent cover letter which doesn't require the signature because we didn't ask name. So we didn't collect any identifiable personal information. So we didn't need to collect the signature. So it's just a one-page consent cover letter. So I sent the instruction to them so that I made a flyer to explain very briefly what we are doing. So we are asking some health questions to know more about the clients, blah, blah, blah. Then also the consent cover letter. And on the cover page, it explains very briefly. So you are invited to participate in this research survey on health and well-being. We are grateful for your help in collecting this important information to help us identify the health needs of clients of the Catholic Health Association of India and its partner organizations, blah, blah, blah. So those kind of 3 steps, the explanations. But of course, at this point, the women who can't read or who are very low the education level probably excluded. Any other questions? So we used 3 standardized questionnaires. So Duke Health Profile consists of 17 items. The health measures for 1, 2, 3, 4, 5, 6 kind of health measures, and the 1, 2, 3, 4 for the 4 kinds of the dysfunction measures in a 1-week time period. I picked this because this is relatively short. So because we don't want to have long survey instrument. So this one has only 17 items, and we can actually measure the variety types of the health issues. PHQ-9 is for the measuring the depression. There are 9 items. Then how often a participant has been bothered by 9 kinds of programs in the past 2 weeks. They're using a 4-point Likert scale. It's like the example is a little interest or pleasure in doing things. PHQ-15 is for the somatic symptoms in the past 4 weeks using 3-point Likert scale. So this is kind of like simply more like a list of the symptoms, like stomach pain, the back pain, the headaches, something like that. So just the simple, just the symptoms. Then they check how often it bothered them. Yeah.
Oh, and if you don't mind repeating the questions when someone asks a question, so that the audience can hear it on the webinar, that'd be. And I do have a question too, though.
Oh, okay. Because okay, yeah.
That would be great. I have a question about how depression is typically manifested in, say, in Hindu cultures. Do you know if it tends to be more somatic with the symptoms versus with the PHQ-9, these various problems? For example, from what I understand, in Chinese culture, it tends to be more somatic with the symptoms versus in the U.S. mainstream culture, it's manifests more through PHQ-9.
So the question is about the depression in the Hindu culture, and if it's the relationship with the somatic symptoms. PHQ-9 has been used in India, but not in the Gujarati. So we don't know about particularly how it works in the Gujarati culture. That's why we actually added PHQ-15 because it's not really cultural. It's just simply the physical symptoms. So having both, we can compare how the depression and the somatic symptoms is similar or different. Yes.
When you were deciding which mental health tools to use, did you consider the SRP-20 that covers the depression, anxiety, and the somatic?
That is longer than the PHQ-9, so that we wanted to make the survey instrument as short as possible. Then actually Duke Health Profile includes some mental health and anxiety, depression. Any other questions? On the abuse experience, so this is kind of a hard part, how to ask the abuse experience. So those are from the Dr. Mieko Yoshihama's measures. So childhood abuse. So there are 2 questions for emotional abuse. This one, there is no subject, but the adults, the mostly parents, make you afraid that you might be hurt, or something like that. So 2 questions for emotional abuse, and 2 questions for physical abuse, push, grab, slap, or kick you. The 3 questions for the sexual abuse, like for example, touch or fondle you or make you touch them in a sexual way. And also the 2 questions about witnessing father beating mother. So basically the questions ask what actually happened, not like the have you abused, like something like that. It's more like the what happened in their childhood.
We just had a comment from a team member in India.
Oh.
She said that there's generally not much awareness about depression in India.
Okay, okay, that's great. So it's just really good to have having a PhD 15 to ask somatic symptoms. Yeah. Thank you. And for the spousal or in-law abuse, there are same questions. Then we ask them to check separately. The 5 questions related to physical abuse, like pushed, grabbed, or shoved the participants. The 3 questions about sexual abuse, like forced you to have sex against your will. And the 6 questions related to emotional abuse, for example, isolated, restricted, or controlled you, or like did not give you enough food, clothing, medical care, etc. And also we asked help seeking for the spousal abuse. So when your husband did any of the above to you, this one, to whom did you seek help? Please check all that apply. So we asked them to check all what they did. Yeah. So they're from the nothing then to the more informal help and the formal help. So there are 219 participants. Actually, when I got the package from India, there are 300. However, there are the surveys which are almost blank, or opposite, checked everything. So I excluded them. Then there are 219 participants which we could use. So it's kind of like we had to drop a lot. We see like they almost blank the surveys here, but we don't see very much checking everything. So I think that they're not very familiar with like filling out the survey very much. So at this point, we probably lost the participants who are not very educated or not really function well. Then among 219 participants, 83 of them have ever married and have the spousal abuse experience. And 84 participants have ever married, then didn't have the spousal abuse experience. So others have never married. So if they have never married, there is no risk of the spousal abuse because we focus only on the spousal abuse. Actually, the participants with spousal abuse experience and the spousal without the participant without the spousal abuse experience didn't have any demographic difference. So the demographic characteristics from entire participants. So they're from 18 to 62 years old, mean age was 32.5, and almost 80% of them have less than 10th grade education. About 35% are currently employed. I excluded domestic employment and also seasonal the agricultural employment. So the currently employed means they are actually working for like a company, the government, and they get the salary. On average, the length of marriage was 8.5 years. And the income per capita per month is about a little bit less than $50 per month. This is actually not so bad in Gujarat. And 90% of them are Hindu in terms of religious belief. 1/4 of them said they are in the highest caste. And 42% live with in-laws. Number of children may look really low, 1.4, but this is from entire participants. So some of them never married, and some of them really never had kids. Among the married participants, it's close to 2. It's still not many, but the participants are relatively young. So they may have more in the future. And 70% of the participants live in a paka house. It means they're made of the solid materials like stones, bricks, something like that. And 1/3 of them live in urban area. So others live in rural. About 66% of them said they got married through the arranged marriage. But that percent was higher for the participant without spousal violence experience. 90% of them said they're married through the arranged marriage. So why the percentage is low for the participants with spousal violence experience? That is because some of them said they are forced to marry. So they chose forced marriage, not arranged marriage. So we had to separate their choice for the arranged marriage and forced marriage. Yeah.
Another comment from your team member.
Yeah.
She said that Gujarat is a comparatively more developed state in India.
Yeah, it's the industrial, I showed some the pictures from Gujarat. It looks like there are a lot of industries. So here is the childhood abuse in the percentage. So obviously the percentage of the child abuse is higher for the participants with spousal violence experience. That is more than 60%. Among the participants without the spousal violence experience, it's less than 40%. It's still high, but it's lower than the participants with spousal violence experience. So below are the breakdown for any kind of abuse. The percentage was higher for the participants with spousal violence experience. In-law abuse, that is same. So more than 50% of the participants with spousal abuse experience in-law abuse also. But that percentage is much lower for the participants without spousal violence experience. That is 12%. And that is same for the breakdown. The most common case is the physical and emotional violence, or the physical violence from in-laws. Among the participants who have experienced spousal abuse, nearly 40% of them said physical abuse only. But nearly 30% said they experienced physical, sexual, and emotional violence from a spouse. and about 50% said physical and emotional. So it means that many of them experienced multiple types of the abuse from the spouse. So this is a help seeking for the spousal abuse. The most common thing is there are parents. So they sought help from parents. The second highest was did not seek help. That was almost 0.5%. Then the help seeking to the formal sources kind of low. So they pretty much rely on informal sources to get the help, or they don't get the help. In terms of the predictors of health, the intimate partner violence had negative impact on all aspects of health and dysfunction. And another factor which affected health among them was actually caste. So people, the participants who are in the highest caste had better social health, lower anxiety, less pain, and fewer somatic symptoms. So main findings are the participants who experienced spousal violence are also the experienced childhood abuse and the in-law abuse. And also the participants who experienced the spousal abuse reported poor the physical and mental health. The protective factor was actually caste. Being in the highest caste was a significant protective factor for the health. So because many of them do not seek any help, and also the majority of them do not seek any help from the formal organizations, probably it's not the good idea to just say that, you know, like intimate partner violence prevention program at the community health organization. Nobody may show up. So it may be good to combine with some like regular health services, like they are providing services for the flu. Then, you know, when the women came to the health organizations for the flu, they may hand some like materials, or they may just a little bit talk about the issue of the abuse. That kind of things may work better than the, like having like abuse only program. And also the women experienced, many women experienced multiple types of the abuse. It's important to develop more community-based programs, not just approaching individuals. And also this is not only about the intimate partner violence, but eliminating any health-related barriers to, for the people in the lower caste should be decreased or eliminated, because the caste is not something people can change. So it's very unfair that if they you know, can't be healthy because of caste. Yeah.
Your team member explains a little bit further about caste. That lower castes are most often discriminated. They tend to not have access to many services and have lower economic status. So, so that's one of the reasons that caste is effective.
So because they don't have access to the resources, they can't have the healthy lifestyle, and they don't have access to the health services, healthcare services. Yeah. So the limitations, of course, this is a self-administrated survey. So that we could survey the only women who could fill it out by themselves. And this is also the cross-sectional, so we don't know what happened first. So like, for example, the in-laws abuse happened first, then the spousal abuse, or opposite, we don't know yet. And we don't have any information about the perpetrators, like spouses or like in-laws or parents. It's just we wanted to keep the survey really short, and it's self-administrated survey, so we couldn't get into the too much details. So outputs, presentation today, and our manuscript is under review, so we are waiting for the outcome right now. So we haven't talked with the Vikas and Tommy about the next projects, because right now we are waiting for the outcome of our manuscript. And they are interested in applying for the grants. So to get the grants, we can be in a much better position if we have publication already. So we are waiting for the outcome of our paper. So I haven't asked what they want to do in a specifically, but maybe she may have some ideas. Krithika. And you may have some of the suggestions for us. Yeah.
Do you know that she folks picked the Gujarat state? Was there a reason they picked there to do the study?
Actually, I don't know why they picked Gujarat. Actually, I thought that they are in Gujarat at the beginning. Then after, when we are working on the translation, I realized they are not in Gujarat. Until then, I thought actually they are in Gujarat. I don't think she's in Gujarat either. Yeah. Yes.
I was also, I guess, wondering, is there some way, because it seems to me that because the survey was only given to those who could read, like there would be a huge bias because all those people who couldn't read. Is there some way maybe that you could administer the survey in a comfortable way to people who couldn't read, so we could get more of that information about the lower class people?
Yeah, I think one of the next step is doing the interviewer administrative survey. But we need money to do it, because all of the staff of the community organization collected the survey as volunteers. But for the interview administrative survey, it takes longer, much work. So I think that we should pay to them. So that's why we want to get the grants at the next step. But that is really important, because we have to exclude the women who can't read. Probably they have a higher risk of the abuse and probably for health. Yeah.
You may have shown this earlier and I missed it, but did you have a percentage of those who reported depressive symptoms? What was it on average?
I do have it. I didn't put it in a slide, or it became first. So actually, the depression, in terms of depression, it was not high. So the score, in terms of the score, the average was 5.7 for the participants with IPV experience and 2.5 for the participants without IPV experience. So it means actually the participants who had the abuse experience had a higher score for the depression PHQ-9. So it means they are more depressed, but 5.7 is not so bad.
What is the scale for that? What's the scale for depression?
PHQ-9. So there is a categorical breakdown. So for the participants with abuse experience, the average was 5.7. It means mild depression. On the participant without abuse experience, the average was 2.5. It means minimal depression. So overall low.
Is the scale for that coded for, it's 9 questions and the coding is 0 to 3 on each question, right? So a maximum score would be
0 to 4. 0 to 4, yeah.
Okay. I know on one study that I worked on, 15 is considered a cutoff where you start to worry about depression.
Yeah, 15 they start for the moderately severe.
Okay.
Yeah. Yes.
So is the 5.7, that's on that scale, or that's
The average of the participant with abuse experience. So, and the
on that scale?
5.7 is the, no. 5.7 is the average score. So it means mild depression. Yes.
Oh. I can pull it for chat.
Yeah.
Go ahead.
We didn't ask what they think about the violence against women. We are doing a separate study about the perception of violence against women in 5 countries, including India, but it's not in Gujarat. So, but in this study, we didn't include that question. Yes.
So that actually has implications for one of your recommendations, which is to do some sort of community-based education to change the level of interpersonal violence. So how do you think about doing that if you don't know what its cultural acceptability is? Do you have a model for that?
Actually, so the question is about a model to implement the intimate partner violence, the prevention intervention programs in the community in Gujarat, if they do not aware of the violence against women as a problem. So there is a huge Gujarat community in Michigan. They are doing intimate partner violence prevention and intervention programs. Those are community-based. So that's actually the Dr. Miyako Yoshihama has been doing it in Michigan. So what they are doing is they started from social activities. They didn't write anything about violence or abuse. So just they said, let's get together to meet with the people in the community. Then they have their dinner together, lunch together. They enjoy their traditional culture together. Then they started including about abuse problems a little bit. Then they put it then in the next time, including a little bit. That kind of thing, they're doing it. Then they actually got the volunteers from the community who got interest in abuse prevention and intervention. Then the volunteers started the awareness programs. So let's think about the violence issues in our community, something like that. So, but it takes time. I don't know how many years they have been doing, but they have been doing for like nearly 10 years. It started from actually a student project at the School of Social Work at the University of Michigan. Yes.
Have you considered like maybe looking at like the whole of the initiatives and outside them? Because I know before that there was an area in India that say that they like 0% because of the outside them. They would have found that, you know, it's a cultural belief that it's something that came before.
The participants of this study, the issue of the dementia or Alzheimer, but the participants in this study are relatively young. There was participants in the 60s, but those are not very common. Mostly they're around the 30s, the 20s or 30s. Oh, how they see the dementia? Do you mean how the people in India perceive the dementia? I don't know much about it. Maybe the Krithika has some answers.
Oh. Some answers, but maybe not to that question. Yeah.
Oh, okay. So, but I don't know about it. About the dementia, the Alzheimer.
Repeat the question, she said.
So how they perceive the dementia or Alzheimer as some like the problems among older people? Oh. Oh, because they didn't know about dementia, the prevalence was very low, 0. But once they're aware, they get more knowledge about it, the prevalence became higher. Oh.
Yeah, she comments on that.
Okay.
Maybe I'll use this microphone right here. Right, there's a few things she said on this. Okay, so pardon me here, get arranged. Okay, so one question was just generally about next steps. And she said that, so right now there are many organizations in the communities working for women, and most of these are non-governmental organizations, so an opportunity is to partner better with the government and also to collaborate. There's a need for greater collaboration, so across these organizations. And then why was Gujarat chosen? The Navjeevan Trust provided a lot of support, and that was support in the form of helping collect the data in Gujarat, so that's one reason that area was chosen. And then, just a moment here. So she says that it's very important to introduce abuse issues in a non-threatening way. Many times women do not report abuse as well. So similar to what you're saying about dementia, there's an issue with reporting. Some of them consider partner violence as normal, quote unquote normal. So there's not very much awareness about mental health either.
Thank you. So I had a project about the intimate partner violence screening at the community organization here at the Malhifree Clinic. We did the screening in summer 2012. We found that the prevalence was very high among them. Then we tried to reach out to the women who have experienced the intimate partner violence to give them like some information about the resources here, but nobody came. We made a flyer. If you have experienced abuse, nobody came. So while we want to try, next is actually we will give them a women's health class this fall. Kai will teach women's health class. this fall. So I'm hoping she will include about abuse issue a little bit in the entire class, but not as a main. So that we will try it here. Then in the future, these kind of things may work in India as well. Like when women came to the health organization for the seasonal illness, then they get a little bit of information about abuse. That's one possibility for the future intervention and prevention programs. But we will try it here first this fall. And there is a good model in Michigan also.
All right. Well, thank you, Akiko.
Is she still on there?
She said thank you as well.
Oh, thank you, Krithika.
Thank you, Scott.
Thanks for coming. Sorry for some of the technical issues, but that's the way things go.
Also, save the date for the Student Global Health
But very appreciated.
Conference on April 26th, this Saturday. The theme is the post-Millennium Development Goal era. So after 2015, what's going to happen next after the Millennium Development Goal? We decide we meet them or not, and then what's next. So long website here, since it's student run, we have a long website, but we encourage everyone to get involved. You can submit a poster abstract as well, so we'll be posting the speaker list. Might be up, but if not, it'll be up very soon. Thanks again, everyone.
Thank you. So I need to eject.
Oh, so